Hello and welcome. We recognize what a unique time this is in the world, and thank you for taking the time to join us. My name is Lorna Neeland. I'm the Director of Engagement at the Swedish Foundation. The Foundation is the fundraising arm of Swedish, the largest nonprofit healthcare system in Washington State, based in Seattle. I'd like to take the opportunity to thank our donors who are joining us today. Without your support, we can't continue to do the innovative work that we do for our patients. This is our second series of education events for women's wellness. We hope you were able to join us last year where we covered menopause, heart health, and healthy aging. If not, they are all located on our events page at swedishfoundation.org, and we have provided a link in the chat. This Women's Wellness Series promotes our vision for the women's health and GYN specialty services. An extension of Swedish, the program will provide comprehensive care for women at every stage of life, including primary care, emotional wellness, overall wellness and prevention, and specialty and surgical care. In regard to how our time together will proceed, I will be asking our panelists a series of questions. And we also want this to be informative and interactive. So please enter your questions in the Q&A at the bottom. We will answer your questions throughout the call and at the end. Now I would like to introduce Dr. Tanja Sorensen, the Executive Medical Director for Women's Services at Swedish, to talk about the vision of this new and exciting program.
Thank you, Lorna, very much, and thanks for inviting me to join the call today. As you say, our goal is to be the primary destination for women's health and GYN specialty services. And our model is focusing on coordinating care that focuses on prevention, wellness, and aging. We are known as a place for OB and deliveries, and we believe that supporting our patients before and after the stage of their life is incredibly important. I had the privilege of joining a couple of groups of really dynamic women who are supporters of Swedish in 2019. And what we did was basically held a sensing session about what they feel their needs are that aren't being met. And it was really fascinating and rang very true for me. The main themes that came across were that women would like someone on their healthcare team who's their advocate in seeking answers and helping them coordinate their care, and having the same sort of support that we provide, for example, for a pregnancy. This would include a holistic approach that would include wellness, nutrition, services such as acupuncture and stress management. Our program, which is already in progress and growing, will provide comprehensive care for women at every stage of their life, including urogynecology, primary care, cardiology, mental health, wellness and prevention, and specialty and surgical care. As we continue to do this, we really are relying on our community to support us. And I am really so thrilled to announce that we have received a transformational gift of $250,000 as seed funding for the program. Innovative projects like this are really only possible with that sort of support from our community. In addition, we're very grateful for gifts of up to $50,000 from a dedicated group of supporters, including members of our Swedish Foundation Board of Governors, who are helping provide educational outreach events such as this Women's Wellness Series. So I'm really excited to introduce the speakers today. We're going to speak, we're going to interact today because they are just fantastic partners in this venture. First, Dr. Rebecca Dunsmoor-Su, who is the medical director for our wellness program and a menopause specialist. She will probably do a little introduction of herself, but she has just been, her ideas, her energy around this has been phenomenal. Secondly, Dr. Ashley Fuller, who is one of our OBGYN physicians who works at First Hill in Ballard. She is a women's sexual health specialist which I think is something that we are incredibly fortunate to have. And you will find her to be both informative and entertaining, I would venture to say, as I have in the past. And then finally, Dr. Peg Maas, who's a doctor of physical therapy, is just, if anyone who's ever met her finds that she's an incredibly dedicated provider who takes on all sorts of pelvic floor problems for women and has really, I think, made so many patients' lives better and is incredibly knowledgeable in this area. So with that, I will turn this back over to Lorna and get the panel going. Thank you.
Thank you, Dr. Sorensen, so much for your leadership. I'd like to officially welcome our panelists, Dr. Rebecca Dunsmoor-Su, Dr. Ashley Fuller, and Dr. Peg Maas. Thank you for taking time out of your busy schedules to be with us today. Before we begin, I would like to ask each of you to tell us a bit about yourselves, your journey, your current practice setting, and why did you choose to focus on women's health? Dr. Dunsmoor-Su, can you start?
Yeah, thank you, Lorna, and thank you, Tanya. So I'm Rebecca Dunsmoor-Su. I'm a obstetrician gynecologist in general practice, and I did my training in the Philadelphia area. And I moved out to Seattle in 2005, took a faculty position at the University of Washington, and then moved over to Swedish in 2013. After I started at Swedish, I took some additional steps. I'd always been interested in menopause and hormones and sort of that part of women's healthcare, but I did the North American Menopause Society training and certification, and then became the medical director for menopause in 2019. And I've been working with Dr. Sorensen on building out the women's wellness clinic concept and the integrated care concept since then. And just have always been fascinated with menopause, which is an area that we don't necessarily train well in residency or med school. And so really have sought out a lot of additional training in that area.
Thank you. Dr. Fuller.
Hi, I'm Ashley Fuller. Thank you for having me. I'm excited to be here. So I am a gynecologist at First Hill in Ballard, and I came to Seattle in 2010 and was with Minor and James for about 5 years before Minor and James kind of became Swedish. And so I've been with Swedish for 5 years. And about 2 years ago, I decided to stop being a generalist OBGYN and just practice gynecology. And I chose to focus my gynecology practice on sexual health. And I did that because I felt like there are so many women who have sexual concerns and sexual problems. And I feel like, as Becca was mentioning, that we don't focus on menopause in our training. We really don't focus on sexual health very much at all in our training. And I had felt previously that I wasn't very helpful for my patients that brought up some of their sexual concerns at some of their wellness visits. And I really thought, this is an opportunity to really help more women who are having these problems, and to really help educate myself in this, but also educate my patients and my colleagues on this really important field, because there's a lot of women who experience sexual problems in their life, and it's a big part of our lives. And so I'm excited to be offering this kind of care to our patients.
Thank you very much. Dr. Maas.
Hello, everybody. I'm so glad to be with you all today, and thank you for the opportunity. I grew up in Vancouver, Canada, and decided at a young age that I wanted to be a physiotherapist, because that's what we called us. And I came to the University of Washington for my degree, my training, and I began working at Swedish at the end of my academic work, and somehow ended up working a lot with pregnant women. And I guess I would say that I fell into this pelvic work because I was working a lot with pregnant women, and my then director said, pelvic health is the new thing for physical therapists. At that time, there was hardly anybody in Seattle. There were one or two. And so I was assigned essentially to take a pelvic health continuing education training, and I was not at all what I ever had in mind that I would do, but immediately fell in love with it, because I would say arguably among the things that physical therapists work on with people, pelvic health issues are so deeply personal and so impactful on quality of life. And so when I started doing it, it just was a perfect fit. And I've never looked back. My focus is on pelvic health in all ages and all genders. So I work with children, I work with men, I work with trans and non-binary people, and I also do a lot of work with women in pretty much all stages of their lives, and feel like it is so important because people don't talk about what's going on with their pelvic health, and I feel that we have important work to do. So I work at Cherry Hill now. I worked at First Hill for 30 years, and then they moved all of the rehab services to Cherry Hill, and we also have people at Issaquah. And so I work with a great team of pelvic health physical therapists, and I just love what I do.
Thank you so much. Dr. Dunsmoor-Su, did you have anything to say before we start?
First of all, Dr. Fuller and I can attest to how much Dr. Maas loves her job, and we refer patients to her on a regular basis, as well as her team and her partners. I just wanted to make Dr. Maas brought up something, and I meant to say it at the end of my introduction, which is that when we talk about a lot of these issues, we tend to talk about them in women. We as gynecologists deal primarily with people who are born with vaginas, but not exclusively. And some of these issues definitely do impact other genders or non-binary folks, as well as all of these things apply to all sexual orientations, because sexual function is important to all people, regardless of their orientation.
Thank you so much for making that statement. So I feel so lucky that all of you are here. So thank you again for being here. Please note that we will be recording today's discussion, and we will send out a follow-up email after we get it all buttoned up. And so today we are going to be discussing sexual health and how it changes with age. So let's dive in. Dr. Dunsmoor-Su, is libido decrease the norm for menopausal transition? And, you know, people always say, do we have a date for this?
So the answer is complicated. Changes in libido absolutely can accompany the transition into menopause. We see it actually go both ways. Some people find that they have a decrease in their libido. Some people find that they have an increase in their libido with the sort of transitional hormones that can happen, especially in perimenopause. Overall, there does seem to be a decline in libido as women transition into menopause. And certainly that can be correlated with the decrease in estrogen as it happens. And it also is hard for us to study because libido is a very complicated thing, which Dr. Fuller is going to tell you guys all about. And so, you know, it's not just estrogen. If it were that easy, you know, our jobs would be very, very easy. We could just add estrogen back and everybody would be fine. But certainly there are a lot of things that go into that decrease during the menopausal transition. Okay,
thank you. So Dr. Fuller, then, to help us understand libido changes with hormones. It seems, I mean, sometimes it sounds simple, but I have a feeling it's going to be a little bit more complex.
Well, our libido is complex, and that's the thing about it. It's not just an on-off switch. It has to do with how we feel about our day, how we feel about our bodies, how we feel about our relationship, how much sleep we got last night, how much stress we're under. And so do hormones play a role in that? Sure. I mean, you know, as we're going through our menopausal transition, we may sleep less well. We may feel less confident about our bodies. We may have more stress just because we don't feel good. I mean, these things affect our everyday life, but definitely affect whether we want to engage in sexual activity with our partners. And so there's definitely a hormonal component to it. And I think a hormonal component to just innate spontaneous desire and how it affects our brains, how testosterone and estrogen affect those things. But is there also just components of, you know, as we age, we have different factors in our lives, different relationships become possibly more complex. We have children or aging parents to deal with. We have careers. I mean, we have more things on our plates. And I think for a lot of women, especially, stress and fatigue and some of these things do play a very big role. So it's not that simple as just saying it's hormones. They definitely can play a role, but it's for sure not the whole story.
Okay. Very interesting. So how does then pain play into the picture and why?
Right. So sexual pain is different than obviously libido, but I have a lot of patients that come to see me and say, I have low libido. And as I start kind of asking more questions about it, they do mention that they have pain with sex. So no one should want to do something that's painful for them. So if someone's having pain with sex, we have to fix that problem first before we can address the desire portion of it. And so I see a lot of women of all ages that have pain with sex. I have some young women who have this problem, but I have a lot of menopausal patients that also have this problem. And that is where estrogen plays a big role. As the longer we go, longer we have lower levels of estrogen in our bodies, and the longer we're in menopause, the drier and tighter our vaginas tend to get. And so it's not uncommon as women are kind of more like 6, 7, 8 years past their menopausal transition that they have more discomfort with penetrative sex. And so that is something that we can usually address with hormones like vaginal estrogen. You don't need necessarily systemic hormone replacement therapy to fix this problem. And I often rely on my colleagues like Dr. Maas for pelvic floor physical therapy to kind of help with the pain, because sometimes when you've had sexual pain for long enough, then your body has this natural instinct to tense up and anticipation for pain. And that actually makes it more painful and works against you. So we have to kind of make the vagina healthier. And then we have to kind of retrain our brains not to tense everything up as we attempt to have our sexual activity. And then we can work on desire. So sexual pain does play a big role. And it's definitely something we have to address first before we can look at desire.
Great, thank you. So regarding estrogen, is that something that women will take orally? Is it something that they actually apply?
Usually we do vaginal estrogen for these kind of things. If it's mostly a vaginal dryness or vaginal pain situation, systemic estrogen sometimes can help, but it doesn't generally. It's not focused at the vagina. And some women who are on systemic estrogen for their other menopausal symptoms actually don't get a whole lot of benefit in the vagina. So we are lucky enough to have actually a fair number of options of how we get estrogen in the vagina with creams and pills and rings and gel caps. And so there are definitely some options, and they are very low systemic absorption of estrogen and are generally very safe for most women. But of course, it's something you need to talk to your provider about and whether it's a good option for you.
Great, thank you. Thank you so much. And I guess that's another thing. What we're discussing now is an overall conversation, but if it's relating specifically to you, we definitely encourage you to go to your physicians or to your provider and help you with your questions. So I'd like to do a poll, and I'd like to ask the audience a question. So true or false, a simple, great, do-it-yourself DIY way to have a better sex life is to do a lot of Kegel exercises. True or false? So take a moment to answer our poll. Okay, so true or false, a simple, great DIY way to have a better sex life is to do a lot of Kegel exercises. And as you can see, 67% of you said it is true. Dr. Maas, please let us know the correct answer and why.
We chose this question because it is really a commonly held belief, I think, that Kegel exercises are the answer to everything pelvic. And as a result, it's spawned a whole world of gadgets and gizmos and apps and methods that you can buy into online. And I have to say the answer is not as simple as all that. And I would probably side with the people who say false. And the reason for that is this. It really depends on what your starting point is. The only thing so Kegel exercises, and I have to say I have a hard time saying Kegel exercises because I admit to having a little bit of an issue with the fact that they're named for Dr. Kegel, who was a white male gynecologist, and also that it's led to a lot of people thinking they have Kegel muscles and Kegel parts of their body. And so, it turns out that 65% or more of people who think they are doing Kegels are actually doing something very different from that. So I tend to just shy away from the word, but for the purposes of this conversation,
Sure.
I will force myself to use that word. And I would say so what Kegel exercises can do for people if done correctly is enhance their strength. It may enhance their the blood flow to the area. But as this conversation is addressing pain with sex, and sexuality issues are much larger than what's going on in a muscle group. And I would also say that there are many people who have too much tension in their pelvic floor and don't know actually how to relax their pelvic floor. And so for those people, doing a lot of Kegel exercises may actually give them an adverse response that might compound their issue rather than helping it. So I would say that really, if you're having issues in terms of pain and sex, what you need is to be assessed for what's going on with your particular body, because we see both ends of the spectrum in terms of maybe it's a weakness issue, maybe it's a strength issue, maybe it's a coordination issue, maybe it's a hormone issue, maybe it's all these things that we're discussing. And so I would caution people against thinking that's the way to remedy their sex life, mostly because if it doesn't do anything for them or makes things worse, they're going to think that was their one shot, and it's much more complicated than that.
Wow, thank you so much for explaining that. I think we all just hear something when we're younger and then assume that that's what it is. So
I have so many great stories. I just met somebody yesterday who has been doing Kegel exercises for a dozen years or more, and really didn't expect that coming to see a physical therapist about this was going to offer her anything new. And as we discussed, she said, "Wow, I have completely missed what I was supposed to be doing with my muscles." So
wow. So Dr. Maas, can we talk about incontinence and previous childbirth? Can that, talk about how patients and
sure, as it pertains to sexual experience?
Exactly.
Okay. So not surprisingly, people who have incontinence feel uncomfortable oftentimes in a sexual experience. They don't trust that they won't leak urine or from their bowels. And so that is can interfere with willingness and interest in participating at all. It also, in many people, will cause them to clench their pelvic floor muscles as a way of avoiding anything leaking that they don't want to leak. And that's really diametrically opposed to what needs to happen if what you are striving for is vaginal penetration. We have to get those muscles to relax and not feel threatened by the introduction of something vaginally. And more complicated, I think, and important to address is that for a woman, arousal is what really makes penetrative sex work. When a woman is aroused, her vaginal canal becomes longer and wider. And if that doesn't happen, there's much more likely to be a mismatch between what might be introduced vaginally and what there's capacity for, and how comfortable or uncomfortable that is. Not only capacity, but self lubrication, and it's a myriad responses. So for people who feel that incontinence is part of the situation, we need to address it from all of those angles. For anybody who's been through pregnancy, whether they've had a vaginal delivery or a cesarean delivery, they may have tissue will have tissue that's been stretched, maybe incised if there's been surgery or repair work done. And that oftentimes causes changes, sort of compensatory responses in muscles and how we work. And the thing about pelvic muscles and the structures around there is that you don't see them and don't feel as aware of them as you might. I oftentimes tell people, if you walk around with a furrowed brow, somebody who loves you will ask you what is upsetting you or disturbing you. But you can have that degree of tension in your pelvic floor because you adapted to pain or you adapted to insecurity about whether you were incontinent or not, and you don't realize it's become baseline, and you don't know that you have a furrowed brow of the pelvic floor, and the people who love you don't know to say to you, hey, you know, relax your pelvic floor. And so this will obviously impact blood flow to the area and arousal and comfort with sex. And if somebody's had a vaginal delivery where there was a tear or they needed to have a surgical extension of the vaginal opening for forceps or vacuum delivery, there may be scar tissue there also that doesn't glide well for an activity that requires pressure and gliding. And if that's uncomfortable, then that sets again that whole sort of spiral of response.
Got it. Thank you. Yeah, it's almost like when you have tension in your shoulders, you're not really thinking about your
Exactly.
pelvic floor, right?
Exactly. You're walking around like this. Yeah. And you can really do that. And pelvic floors are sort of the hapless victim, because when we're stressed, but we need to keep a sort of an appearance of relaxed countenance, pelvic floor is oftentimes the seat of people's tension and worry and anxiety. And we just oftentimes can't perceive it ourselves.
Mm-hmm. So there is a question that came in. It says, can you describe exactly what area the pelvic floor encompasses? And I open that to any of you.
Does one of you want to take that? Okay, I'm on it. I'm on it. This is my daily talk. So pelvic floor, when we talk about pelvic floor, we are talking about a group of muscles, but also nerves that run through there and blood vessels and connective tissue, what we call fascia. And what we're really talking about, if you can envision it, is the bottom of the bowl that runs between the pubic bone in the front and the tailbone in the back, and between the sit bones. And it encompasses vaginal opening and anal opening and all, you know, sort of the vulva and anus, everything that runs through there is fair game. And so oftentimes when we talk about these muscles and their function or dysfunction, it includes what goes on with their bowels and their bladder, and oftentimes it's not just a single issue. Does that answer that question?
I believe so. Thank you very much.
It's essentially 3 layers of muscles, and they all ideally work together as a team. Okay,
great. Another question came in. My mother and her mother didn't enter menopause until her late 50s. Can I expect the same?
I'll grab that one if you don't mind. And the answer is yes and no. We often ask you about your mother's experience to get some kind of idea of what you might be expecting, because 50% of your genetics do come from your mother, but the other 50% come from your father. So that can impact your menopausal age, as can stresses to the ovaries. Medications might stress the ovaries. There are, lots of things that can impact that age. So it's not a perfect predictor. We can't say, because your mother did this, you will do that. There are differences, but it can maybe give you a hint about what might happen.
Great, thank you. Dr. Maas mentioned vaginal rejuvenation. And so Dr. Dunsmoor-Su, can you talk a little bit about that? We hear a lot about it. Is it a thing? How does this play into sexual function?
So I'm glad you asked me about it, because much like Dr. Maas, and I agree with her, doesn't like the word Kegels, I hate the word vaginal rejuvenation. Your vagina does not need rejuvenating. It needs good care, and we should take excellent care of our vaginas and treat them with medications and other things that will help them to be healthy and elastic and able to be aroused. But I think oftentimes when you hear about vaginal rejuvenation, what you're hearing about are devices that are marketed for better sexual pleasure, vaginal tightening, things like that. There are tons and tons of devices on the market. In my practice, I use one device. It's called the Mona Lisa Touch. It's a FDA cleared laser, which has some data for use in treating the thinning and loss of elasticity that we see with menopause. And so sometimes we'll use it for that reason for women for whom vaginal estrogen is not an option or has not worked. It can be an additive thing. We sometimes use it also for some vulvar and vaginal disorders. A lot of the other devices just don't have any data for what they do. So we just don't know.
Okay.
None of these devices are what we call FDA approved. So none of them have, by the FDA, been approved for a particular indication. So the FDA hasn't said, okay, this is indicated for this. And that means that a lot of them are also uncovered in our cash pay services, unfortunately. So when women come to me and talk to me about vaginal rejuvenation, I say, well, really what I need to know is, what are you trying to achieve? What are your goals in this? And let me give you the sort of an explanation of all the things that we have in our armament that might help you achieve that goal.
Mm-hmm. Great. Thank you for talking about that. So I would like to do another poll. And this is another true or false. To deal with sexual pain, is systemic hormone therapy is needed? To deal with sexual pain, is systemic hormone therapy needed? True or false? Give a moment here. And so looks like 100% of you, oh, thank you. 100% of you believe it is not true. False. To deal with sexual pain, is systemic hormone therapy needed? Okay, Dr. Dunsmoor-Su, can you first talk to us rather, about systemic hormone therapy? What is it? And then is
Sure. So I'm happy to. We often, as providers, talk about systemic hormone therapy. And what we mean by that is taking estrogen and or progesterone, either through your skin or through your mouth. Or there's one way you can do it vaginally with a higher dose ring, but I'm going to sort of leave that to the side because it's not a method we typically use, although it can be used. And what we mean by that is we're giving you enough hormone that you are seeing it in the bloodstream, and your body can react to it. Your brain will sense some of it. Your tissues will sense some of it. That type of hormone replacement therapy can be very beneficial for women, but it's primarily used for systemic symptoms. So symptoms like hot flashes, night sweats, sleep disturbances. Sometimes we use it with some mood imbalances. And so certainly it's really, really beneficial for that. If someone comes to us with purely vaginal symptoms, you don't really need to give the whole body hormone in order to treat those symptoms. Generally, we can give it locally at the level of the vagina and achieve good results for those tissues without giving a whole systemic hormone dosing. That's really important to mention because one of the things we know about hormone replacement therapy is that it's safest to use if started within 5 years of the menopausal transition, and really is considered not safe to use systemically if you start after you've been in menopause for 10 or more years. But many women may not have vaginal symptoms until they're 8 or 10 years out into their menopausal transition. The use of vaginal estrogen at that time is still considered safe because there is just so little that is absorbed throughout the body that you're not taking any of the cardiovascular risks that we think about if you were to start a systemic hormone at that time.
Great, thank you. I'm going to pivot for just a moment. We have a question about, can we discuss sexual positioning and clitoral stimulation? Where or who do we get more information about this? And I don't know, Dr. Fuller, this seems like this is in your wheelhouse.
Yeah, so this is a great question. So, I talk to a lot of patients who come in with, especially patients who have orgasmic dysfunction or have a hard time achieving orgasm, that most women actually can't reliably achieve orgasms just through penetrative sex. And so for a lot of us, we need clitoral stimulation. And so sexual positioning can be something to kind of experiment with and trying to get in a position where you or your partner can provide clitoral stimulation. I think a great resource is a website that I recommend patients to called omgyes.com. And it's a website where they have basically tried to kind of get some scientific data behind how women experience pleasure and kind of, discuss that we as women never really are taught how to give ourselves pleasure, except for oftentimes by our young, often male partners when we're first experimenting with sex, who really don't know a lot about women's bodies either. And so it leaves a lot of us not really knowing exactly how to reach orgasm or how to have sexual pleasure. And so it's a great website that kind of explains how different women They basically ask 1,000 women how they achieve orgasm, how they get their sexual pleasure. And so looking at techniques and things like that. It's not porn. And there is a paywall to it to get to subscribe to it. But I recommend it for a lot of patients who are interested in finding out more about how to actually achieve sexual pleasure.
Great. So I'm sure everyone's like, what is the website? Go ahead and talk about it. And then we will also put it in the chat in our follow-up as well.
Yeah, it's called omgyes.com.
omgyes.com.
I wanted to add one thing that I often recommend to patients. I love omgyes.com. It's a great website with a lot of really great information for women. Another, if someone's hesitant to be on the internet with this stuff, I often recommend a book, and it's called Becoming Clitorate. And that's by Dr. Lori Mintz, and we'll put that in the chat as well. She is a sex therapist out of Florida who's also written a great book that Dr. Fuller may mention later about libido. But it's a great book exploring how to understand your own body and sexual pleasure.
Awesome. Thank you. All the resources we will take. So if somebody goes on hormone therapy for menopause, how long does a woman stay on hormones? Does she stay on it for life? The question from the audience.
No, women do not necessarily stay on hormone therapy for life. And when I talk to patients in clinic, what I often say is there are different groups of women who are on hormone therapy for different reasons. So if someone's on hormone therapy primarily because of hot flash type symptoms or night sweat type symptoms, often they really only need to use it for 2 to 5 years to get them through that transitional time where they're symptomatic. And then we can taper them off and they do great and the symptoms are gone. Although those symptoms can last out to 10 or more years, they rarely do. Second group of women I work with are having a lot of more vague symptoms, maybe some joint discomfort, achiness, brain fog, cognitive issues. And they're very high-powered women and they're working in their field and they just can't tolerate those symptoms while being the person that they want to be. And so we talk about continuing their hormones sort of through retirement. You want to be out in the world and functioning, let's continue these hormones. And then they say, I'm retired now. I'm okay taking these symptoms for a couple of months or years, and they want to come off at that point. I do have a small subset of women who feel better on their hormone replacement therapy, and they continue it indefinitely. And they do continue it for life because they just feel better when they're taking it. And that's an okay choice as well. The risks and benefits of hormone do change over time, and we have that discussion over and over again when I'm working with a woman. But a lot of the risk has to do with when you start them, more so than how long you use them.
Great. Thank you so much. Dr. Fuller, can we talk about how to help women with achieving libido again? Are there medications? Are there, what can be done for that?
Right. So there are some medications, but when I have patients who come in to see me for low libido, I try to take a big step back and look at the big picture of what's actually affecting their low libido. So I call these the biopsychosocial factors, because there's a lot of things that go into this, like I was mentioning before. So we talk about any medical problems they may have, any medications they're on that may be affecting their libido. Big one is SSRIs or antidepressants can have a big effect on our libido and our actual sexual function. I talk about any issues with their partner, talk about stress and fatigue in their lives, ask them about any sexual pains. We kind of already talked about any hormonal changes they've had, like where are they at in their menopausal transition, things like that. So I try to look at those kind of things and try to help patients determine what things they could change to kind of optimize things. I often recommend some books they can read. Dr. Dunsmoor-Su kind of mentioned Lori Mintz, and she has she wrote that Clitorate book, but she also wrote a book called A Tired Woman's Guide to Passionate Sex, which is also a really great book. And so there are definitely some things to kind of think about there. And then I often talk about sex therapists, because for some couples that feel like has really taken a toll on their relationship, the low libido of one partner or both partners, that sometimes it's hard for them to kind of reintegrate sexual intimacy in relationships. And so sometimes sex therapy can really help with communication and kind of rekindling that. Are there medications for low libido? There are. There are 2 FDA-approved medications for the treatment of HSDD, which is hypoactive sexual desire disorder, in women it's FDA-approved in premenopausal women. They can be used off-label in postmenopausal women. They are not perfect medications. They do have some side effects, but they have been shown to increase increase desire and decrease the stress about their low desire. And I do think they can be very helpful for the right patient. And then there's always testosterone. And so a lot of women come in and we talk about testosterone. Unfortunately, testosterone is not FDA approved for the treatment of low libido. There probably never will be, unfortunately. There actually is some good data showing effectiveness in postmenopausal women using small doses of testosterone topically. When I do prescribe this for women, I usually look at those biopsychosocial factors first, because this is not like a home run, like you take testosterone and all of a sudden like things are way better and you want to have sex all the time. It's not going to fix relationships. It's not going to take away your sexual pain. Like, we have to really look at what are the underlying causes for your low libido. And then if we kind of fix those things or optimize them the best that we can, sometimes those medications can be helpful. But the testosterone, when I do prescribe it for women, and we do have to have a talk about, side effects and risks, and the fact that this is not FDA approved and that we don't have a lot of great long-term safety data on it, but it definitely can be helpful. So I'm thankful we have options.
That sounds great. Thank you very much for talking through that. So, we just have a couple more questions left. So if any of you watching have any questions, please feel free to put them in the Q&A. And we have this wonderful wealth of experts here to help you with your questions. Dr. Maas, tell me about pelvic floor physical therapy, because I was just learned about it last year. And I think, like me, a lot of us didn't know this was a thing and could find it a little bit awkward. How do you get past that with your patients?
I'm so glad you asked that. And I'm just sitting here with a big smile on my face because I appreciate Dr. Dunsmoor-Su and Dr. Fuller so much. It is such a pleasure working with. I think that the multidisciplinary and interdisciplinary team we have is outstanding, and just makes me so happy because I've been doing this for a long time and we haven't always had such excellence and humanity in our providers. So yes, awkward. I understand people feeling awkward. I try to I take the awkwardness as a personal opportunity to try to get people feeling comfortable. And I do that just by being straightforward, and I use humor when it's appropriate. And I think the focus of the care I give is to emphasize figuring out together what a woman's body needs and what the starting point is, and try to cultivate that sense of curiosity about what your body's doing that you might not have been informed about, that you might have been living with misunderstandings about what's right and what's going on with your particular body. And I find that the education and the curiosity and the collaboration tends to engage people, and they tend to generally, most common thing is that when people leave, they say, if I'd known it was going to be this easy, I would have come years ago, which is lovely. So physical therapy in the pelvic health realm is kind of this convergence zone of musculoskeletal issues, how you move, what you want to do, pain, sexual concerns, bowel and bladder, and all of that kind of comes together in my practice. And so it starts with an evaluation and talking with people about what they need and what they're hoping for, much as Dr. Fuller was saying, and as I know Dr. Dunsmoor-Su does also, and tailoring it to what they need. So in the course of an evaluation, I'll watch how people move, how they walk. I see young athletes and older women also who want to be able to run, and their pelvic floor issues are interfering with that. So we might do a running evaluation. And the nitty gritty, the thing that I might do that might be different from what people are accustomed to a physical therapist doing, is that after I show people the anatomy and we've talked through kind of what's going on for them, I'll ask for their consent to do a pelvic evaluation. And I'm not palpating deeply for it's not like an exam. It's somewhat like an exam that a gynecologist might do, but somewhat different also in that I'm not palpating their bladder and their uterus and ovaries. And I don't go that far in, but I use a gloved finger and lubricant. And I do a vaginal exam from a musculoskeletal perspective if they consent to it. And with that, I always tell people, whereas I think sometimes we check out when we're having a pelvic exam, this is a collaborative exam, and I want them to tell me, oh, that hurts, or funny, I can't feel that, or that feels really tight. And I may ask them to activate and release their pelvic floor muscles so I can figure out how coordinated they are, how strong they are, how effective they are, what hurts inside, and from that, figure out what I can add to the story, and we decide how often I would need to see them and what they need to do for a home program, whether it's strengthening or learning to relax their muscles or learning the timing of their abdominal muscles versus their pelvic floor. There's a lot that's nuanced. And I make myself available to people so that if they feel uncomfortable, they know that we can change things. I do every so often see somebody who does not consent to an internal exam, and I tell them I'm going to do my best to help them anyway, and we'll guess based on what they're experiencing, what we might be able to do. But it really is very individual.
Wow, thank you very much. I've learned a lot about the work that you do, so thank you very much.
My pleasure.
We have a couple of questions, so I'm just going to open it up to all of our panelists here. So the question is, I understand that a low-level antidepressant can help with night sweats, but then also can contribute to low libido. Can someone comment?
I can comment. So, I mean, this is true, right? So, I mean, if you are someone who has a lot of night sweats and you're not a great candidate for systemic hormones that Dr. Dunsmoor-Su was talking about, sometimes we do offer antidepressants. There's actually one antidepressant that is FDA approved for the treatment of this. And so that is an option, but yes, you have to take into consideration that could be a side effect. Now, you also could take into consideration that perhaps sleeping better at night would make you want to have sex more. So, I mean, there is a possibility that it wouldn't. A lot of the antidepressants do show that do cause some lower arousal, lower libido, and harder time achieving orgasm. So if someone is on one of those, then it is worth looking at how we can change that around or modify it. There is one antidepressant, Wellbutrin, that tends to have less sexual side effects and can actually sometimes be added to other antidepressants to kind of overcome some of those side effects. So it's somewhat complicated, but you could look at it that way. But I sometimes think when people have if their mood is improved and they are sleeping better, they often have better libido. So it's not a hard and fast rule, I would say.
Great, thank you. We've got another question that's come in. I've heard several ways that I could benefit from services at the Women's Wellness Clinic. I have a Swedish primary care physician. How would I go about accessing this type of care?
Excellent question. So the nice thing, and Dr. Maas alluded to it, we work in a really collaborative way at Swedish, and it's incredible for us. A lot of Swedish primaries know where to find us and refer into us. Dr. Fuller and I are located at Swedish OBGYN Specialist First Hill. And long-term, the Women's Wellness Clinic will be sort of a separate entity, but still under the auspices of Swedish OBGYN. But certainly you can look us up on the website. We're more than happy to share care with our Swedish primary colleagues. And we always make sure that notes go back and forth so everybody knows what's going on. And everybody knows why decisions are being made, and we can always talk on the back end if the primary care has some concerns about maybe what we recommend. We'll often have an exchange in our medical record system so that everybody feels like they're on the same page and providing comprehensive care for patients.
Great, thank you very much. Gosh, it's already 12:50. The time has just flown by. Thank you very much to each of you for being here. I'm wondering if each of you could provide some concluding thoughts. Let me start with Dr. Fuller.
Sure. Well, I just want to say thank you for having me. This is really fun. I agree with Dr. Maas. I feel really lucky that I get to work with Dr. Dunsmoor-Su every day and Dr. Maas. collaborate with Dr. Dunsmoor-Su a lot, and I send patients to pelvic floor PT on a daily basis, multiple times a day. And I feel it's so wonderful to know that I can confidently refer patients to my colleagues and know that they're going to get the help they need. So I feel really lucky to work in this field, and also with these other providers. And I would just say, if you're attending this, I'm really excited that you took the initiative to kind of look more at this aspect of your life. And if you're struggling with any of these issues or have questions about this, know that there are providers that can help you. I think that, especially if your concerns are sexual concerns, a lot of patients don't feel comfortable bringing up their sexual concerns with their providers, either because they're embarrassed or they just don't think their providers can help them. And I give talks to residents and to other OBGYNs and talk to people about initiating the conversation with patients, asking them about their sexual health, because it is a really important part of our lives. And we as providers should screen for sexual problems and let patients know that we're okay talking about it and we want to help them with it. So if you're in that group, I'm glad you came to this. And if you need more help or resources, please reach out. Like Dr. Dunsmoor-Su said, you definitely can make appointments with us, and we can try to help you in any way that we can.
Thank you so much. Dr. Maas.
That delay while people find their unmute. Ditto on all of that. And I would add that studies show that that people with pelvic issues on average take 6 years before they mention it to their provider. And I certainly see people, for many years, I've seen people who are referred because of incontinence. And when I ask them about pain with sex or sexual concerns, I can't tell you how many women have said, well, just the usual amount. And when I say, really, sex should not be painful, they look kind of incredulous. And it hurts my heart a little bit to think that people are not knowing that that's not an essential. And I guess the other thing is, just in the last 2 weeks, I've started new patients who have each said, I was getting all my information from the internet, from websites, from chat rooms, and what you have to say is so different. And I'm just going to go tell all my friends. And so I would second what Dr. Fuller is saying. Congratulations if you're thinking about doing this, and if we can just encourage you to think and realize that your story is different from every other story. And you're not going to get the information from the internet that really is directly relevant to your story, and especially if they're trying to sell you something. So please, in the interest of care for yourself, get somebody with some expertise to assess you as an individual.
Very well said. Thank you.
And thank you for this opportunity.
Thank you. Dr. Dunsmoor-Su, can you give us your final thoughts about?
It's going to be hard to top those two because I agree with everything they said. I guess I would add that one thing that I feel like we're really lucky to have at Swedish is a group of providers who practice what we call evidence-based care. And we always we're on the lookout for the next best thing, and we love to read papers about it. But we try to have a foundation of good medical science behind what we recommend to you. And that's important, especially in things as nuanced as sexual health care or menopause care, which can be a really confusing and large field. And there's a lot of noise about both of those things out there in the world. And so having someone, you should feel comfortable that when you're making decisions, the person who is helping you to make those decisions is explaining where their recommendations come from and why they're making them. And we always try to do that.
That sounds great. So we are going to be doing more of these types of events throughout the year. We started this effort last year during the pandemic when everything shut down. We were going to do this in person. And so we decided to go virtual. And so if you go to swedishfoundation.org and go to virtual events, you'll see all of our past webinars that we've had, and we will upload this one as soon as we can. And then also, we'd love to keep in touch with everybody about the Swedish Women's Health and GYN specialty services here. And it's just going to be really exciting. So thank you so much, everyone, for being here. I'd like to thank Dr. Sorensen, Dr. Dunsmoor-Su, Dr. Fuller, and Dr. Maas for joining us today. At the end of the call, there's going to be a short survey that's going to pop up. If you have the time, please let us know your feedback that you may have. If you also have any questions regarding women's wellness and GYN specialty services, please feel free to reach out. I believe my information will be showing on the screen here, and it will also put this on the chat. I really would like to thank our donors who helped make events like this possible. Thank you so much for caring about women, caring about Swedish. And to each of you here today, we appreciate the lively discussion and participation. Please know that all of us at Swedish cares about you, and we are here for every step of your health journey. And we wish you all a great rest of your day. Please stay safe and healthy. Thank you again.